symptomatic 2 years ago. Then she noticed a small swelling below and behind the left ear. That swelling was insidious in onset and gradually progressed, but in present size. Swelling was not associated with pain, fever, no history of any rapid increase of in size any time of period, and no history of increase in size of swelling associated with pain while mastication, no difficulty in opening mouth, and there is uh, no pain on having food. There is no history of any ulcer in mouth, no history of dryness of mouth, eye, and joint pains. There is no history of difficulty in swallowing and difficulty in respiration, no history of earache, no history of features history of facial nerve palsy like unable to frown, uh, unable to close both eyes, and drooling of saliva from the angle of mouth, and there is deviation of angle of mouth on smiling. No history of other swelling over the face and neck region, no history of loss of weight and appetite, no history of symptoms, history of metastasis like headache, seizures, and chest pain, hemoptysis, cough, pain, abdomen, and jaundice. In past history, this patient is not a non-case of diabetes mellitus, hypertension, CAD, tuberculosis, bronchial asthma, CV, and epilepsy. There is no history of any surgery in past, no history of any radiation exposure. Personal history, she takes mixed Indian diet. Her bowel and bladder habits are regular. She sleep adequate and appetite normal, and there is no any type of addiction. In family history, there is none of her family members suffered with similar illness, and there is no history of any death related to cancer. Now I would like to summarize my history. 32-year-old lady who is a housewife having a painless gradually progressive swelling below and behind the left ear for 2 years of duration without any history of increase in size of swelling while mastication, and no constitutional symptoms, and no history suggestive of nerve involvement or weight loss.
Wait, just wait. Don't rush through it because there's some confusion, therefore we did not stop you. Any questions in the history, Dr. Dipankar?
Why you took the history of distant metastasis in a parotid swelling?
Sir, I am not getting.
Why did you take the history of distant metastasis in a parotid swelling?
Sir, it can be carcinoma also. So.
Why is he asking you this question? Is because parotid tumors don't normally go that far, most of head and neck cancer. So what would you say?
Normally parotid tumors don't go to liver. So that was also when you said metastasis. You said no pain in abdomen. So that's what, it doesn't metastasize to liver.
For a parotid swelling, probably you asked too many questions. Now, it is important that you also take home, along with them, the whole purpose of asking this question. He asked you because it's a lot of unnecessary questions that you have asked in the history for a parotid swelling. It's a very innocuous little swelling in the parotid region. Okay? And then you took the history of inability to close the eyes, etc. Once you say no history suggestive of facial nerve palsy, we generally believe that you covered it up. Let the examiner ask you what are those features, rather than you telling and rattling out all the list, because that's like opening up unnecessarily something which you've not been even asked. Yeah? So, I mean, I had a few more questions, but we will do it at the end of the examination when we summed up your case. Since you are summarizing, I thought I'll ask this question. Start the examination.
I have examined my patient after taking verbal consent for examination and taking photos in a well-lit room with adequate exposure and in presence of a female attendant. Patient was conscious, coherent, cooperative, and well-oriented to time, place, person. And performance status on Karnofsky performance status was 100. BMI 25 kg per meter.
I'm sorry, I'll have to stop you here because I can do it later on also. But before we go further and we forget the point, what is 100 Karnofsky?
She is able to do.
Answer the question. What is 100 Karnofsky? Patient should not even have a symptom of a disease. The moment a patient has a symptom, it is 90. So this 100 is not possible. hopefully you are 100, but I don't know, even that is possible. There's some symptom somewhere. So it's unlikely. So 90 is what is likely. If patient has symptom, that's not a symptom. Okay? Now proceed. So it's safer not to use 100.
Generalized lymphadenopathy and bilateral pedal edema. Pulse rate was 82 per minute in right radial artery, which was normal in volume and regular in rhythm. BP was 126 by 80 mm of Hg in right arm position.
Hello.
C was afebrile and respiratory rate 14 cycle per minute. On inspection is solitary swelling in left parotid region, which is approximate 3 into 3 centimeter size and globular in shape, and with a smooth surface, well defined and rounded borders, which was obliterating the left retromandibular groove and raised ear lobule. There is no visible ingos vein, scar and pulsation, ulceration or the swelling, skin or the swelling normal, and on clenching the teeth, swelling becomes more prominent. In intraoral examination, there is no bulge in lateral wall of pharynx behind the third molar teeth, and the parotid duct opening normal, no discharge, and lips, buccal mucosa and tongue healthy, and bilateral tonsillar pillar normal in position, and uvula in central position. She was able to close both eyes normally, able to frown, and no deviation of angle of mouth. No other swelling noted in face and neck, and contralateral parotid and other salivary glands normal. On facial nerve examination, there is no feature suggestive of facial nerve palsy. There is no absence of frowning, wrinkles on frowning, and she is able to close eyes, and she is able to blow, and she is able to whistle, and there is no deviation of angle of mouth on smiling and clenching of teeth. And on palpation, there is no local rise of temperature and tenderness over the swelling. All inspective findings like sight and 3 into 3 centimeter globular, which is smooth surface and with well defined and rounded margins, and inconsistency firm in consistency confirmed, and swelling is mobile and non pulsatile, and swelling is not fixed to skin and underlying tissues. Parotid duct normal on palpation. Parotid duct opening is normal, no pus discharge or bleeding from the opening. On compressing the gland, and deep lobe not palpable. Rest of oral cavity examination normal. Temporal mandibular joint movement is normal. Patient is able to close eye against resistance, and opposite side parotid gland, including the other salivary glands, also normal. No cervical lymphadenopathy. On auscultation, there is no bruise over the swelling. On systemic examination, CVS S1 S2 hard, and there is no murmur. Respiratory system, bilateral vesical breath sounds present, no added sounds, and CNS, no focal neurological deficit present, and per abdomen soft, non-tender, no palpable lump. Spinal scalp examination normal. Now I would like to summarize my history. A 32-year-old lady has come with a painless, gradual, progressive swelling just below and behind the left ear for 2 years of duration. On examination, a globular swelling of size 3 into 3 centimeter present in left parotid region with raised ear lobule and obliterating the retromandibular groove. Swelling is not fixed to surrounding structure. Deep lobe couldn't be felt, and parotid duct and ductal opening appears normal. No features of facial nerve palsy. Opposite side parotid gland examination is normal. My provisional diagnosis is left parotid tumor, probably benign in origin, most probably pleomorphic adenoma.
One question Dr. Dipankar asked you, which was very important, because you shouldn't take unnecessary history. There were a lot of unnecessary history. And then Dr. Murtaza Akhtar added up that you few more things, abdominal pain, etc. So that I hope you have learnt, because there's some initial hiccups with I think audio visuals. So are you all able to hear us? Yes. Those on the first floor. Okay? So anytime you can't hear, you let us know. We'll get it fixed. We are trying. Hopefully it will work out. So that somebody says at one point, pain around or swelling around the left ear. Now once you say it's parotid region, then it becomes parotid region. You're summarizing it. And in a postgraduate examination, don't keep beating around the bush. What are the boundaries of parotid region?
Yes, sir. It bounded by 4 lines, 2 horizontal line and 2 vertical line.
Okay.
Upper horizontal line and lower horizontal line through the lower border of mandible, and anterior vertical line is through the midpoint of zygoma, and posterior vertical line is through the
Right. And what is its significance?
knee swelling in parotid region. It will most probably it will be from parotid unless
So it's taken as a parotid swelling unless proven otherwise. So that is the significance. So once you say that, it saves you all lot of trouble of explaining 2 centimeter from here, 1 centimeter from there, etc. Now I am not going to get further into it. They will have some questions to ask. I stopped at that point. Do you have any other question of Dipankar in relation? Ram?
Just very quick points. One is that when you were saying that there is a swelling which is below and posterior to the ear, as an examiner I'd be happy if you say like ear lobule rather than ear. Ear is like in scientific parlance. So ear lobule would sound better. That was one. Number two, you were using abbreviations. In the examination, whatever you speak, in your mind it should be shining like a lighthouse that you have to impress the examiner so that he passes you very smoothly. Blood pressure mmHg, that wasn't good. Say like 120 by 80 millimeter of mercury. CVS S1 S2, cardiovascular system. You got what I'm saying? So then the verbal consent. I have my own reservation about the verbal consent, because any consent taken verbally is as good as not taking any consent. So in the examination, I also believe that in the OPD setting, we can't, keep on taking written consent. So, avoid that word verbal. The patient was examined after taking consent, because verbal consent carries no meaning. So that was something. And another thing, when you were describing this swelling, if the surface of the swelling is smooth, it is smooth. You can't change it. Having said that, most of the pleomorphic adenoma, their surface is not smooth. They are slightly irregular. So, and now two quick question.
Now, what you have said is understood now. What will be your diagnosis provisional in this case?
Given that.
my provisional diagnosis is benign left parotid tumor, most probably pleomorphic adenoma.
Why do you say altogether pleomorphic adenoma only, not the other component?
Because pleomorphic adenoma is most common, sir. It's 80% of benign tumors.
Mostly pleomorphic unless proven otherwise. Agreed.
Any other thing which can go in favor of this? Not adenolymphoma. Now I just come to differential part between adenolymphoma and the pleomorphic. I'd like to know.
Preauricular lymph node, but this one is also less likely because swelling is
No, my question is differentiating it from adenolymphoma. That is Walden's tumor.
yes, sir. Warden's tumor is most common in males, and it's bilateral, and its most common site is tail of parotid.
And what about
Did you
its
say it's
consistence?
bilateral always? It is occasionally it can be bilateral.
Yes, sir. It's
Not always. Age group?
in young adults. Warden.
And it is always above 40. You remember that? Because these are very small questions. If you don't answer such small questions, that if you say young, while the book says it is 40 plus, so it will go against you. It will be taken as a very big negative point. Of course, level, you very rightly said, the parotid is the upper region, mixed parotid, while the adenolymphoma in the lower part. Another consistency-wise, any difference between the two?
So this is hard in consistency, firm in consistency.
Which one?
My patient swelling is
I'm talking about the Warden's tumor.
Yes, that will be cystic consistency.
Sure. So you should be very clear. 4 points only, which can just distinguish between the two.
I think you got the point. Anything in the history and examination which you want to ask, Dr. Murtaza?
You mentioned about bulging in the oral cavity.
Yes, sir. If
Actually, when you are talking about parotid, it bulges at only one point.
yes, sir.
You mentioned it later on, but you say intraoral bulging. The deep lobe usually pushes the tonsillar pillar.
Yes, sir.
So if you
You
say
should
that,
say that tonsillar pillar is not displaced. That's why it's a very, very crude term. I think you must have understood the sense of what they're all trying to tell you. There's so many unnecessary words. I agree with the findings. It could have been much, it could be more precise and you would have reached the same conclusion. The most common, the question would be, why do you think it is benign? First, why do you think it is parotid? Then why do you think it is benign? And why do you think it is pleomorphic adenoma? That part would be covered. And when you're discussing it, the region would come into play automatically because this is lying in that region. That's why I think it's a parotid swelling. Now you looked for the deep lobe. Now what is your thought on bidigital examination? Should it be done? Should not be done?
Yes, sir. For deep lobe palpation, did by digital examination.
Did it?
Yes, sir.
How did you do
Sir,
it?
yes, sir.
How did you do it?
Sir, I with my left index finger, I felt the deep lobe inside the oral cavity, and with the right hand, I post the swelling.
So there are two cardinal mistakes that one makes. One, if you have not done it, don't say you've done it. And if you don't know, don't do it. So you're wrong, actually. It's not done, it's inspectory finding. Because if you do it normally, patient will have a gag. So you can't do it. When it is enlarged, it can push itself out of that area. Then you may possibly can do bidigital examination. And you have not done it in this case. So why should you tell me?
Yes,
If it is not visibly displacing the tonsillar pillar, as Dr. Murtaza was saying,
yes, sir.
what business do you have to palpate for it? It's an inspectory finding, mostly. I know it is written in many places you can do it, but then that is, you have to try doing it. I've tried doing it, it's tough in a patient who doesn't have an enlarged deep lobe. But if the deep lobe is enlarged, then it is possible to feel it because it comes out of that area. Otherwise, you'll stimulate for the gag, and you know where we are going, gag reflex would happen. Okay. Now, anything, Dr. Saab? Move on. Now, I think I have few things which you should take into account. Here, you probably made up for any case, anywhere, anytime. If there is a patient with hernia, nobody is interested in the performance status. You should be sensible enough to use it at the right place. Similarly, like Dr. Dipankar asked you about the metastatic thing, symptoms in parotid tumor. Parotid is not known to go that far. And then abdominal complaints, etc. So I thought there was a little turmoil in the morning, but I hope you got the take home. So don't unnecessarily use words which you cannot defend. Is that okay?
Yes, sir.
Why do you say it's a parotid swelling?
Because it's first in this swelling is in parotid region.
Okay, why do you think it is benign?
Because it's since 2 years and young is it's
So
not
points in history and points on examination. That's how we normally classify.
Yes.
What are the points in history?
point in history is gradually increasing in size, and young is
Okay.
Yes,
And no features of facial love involvement.
Features
You have
of
taken
facial
that
love
history. And on examination,
on examination it's not fixed to any skin and masseter muscles and any surrounding structures, and
consistency,
on clenching it's
consistency.
consistency also it's form. So
So we have to touch basic things first. And you mentioned about no visible pulsations. It's not pulsatile. Why did you say that?
sir, if any carotid swelling, then that's
Is it lying in the carotid region? See, that's what I'm saying. I remember the blunders that were there. How would it be? Which carotid would come there?
sir, external carotid artery.
External carotid artery can reach parotid region? No, I am not failing you. You are failing yourself. Can it reach there? What lies deep to parotid? Which carotid lies deep to parotid?
Yes, sir, external carotid artery.
External lies deep to parotid. See, that is why it is important
Yes,
to
sir,
have.
it's entering the parotid and deep to parotid is internal carotid.
That's what I'm asking.
Yes, sir.
And external carotid won't be there.
Yes, sir.
Would it be there?
Sir, it deep to parotid, the deep lobe, sir. The internal carotid artery.
No, you said external carotid artery. Now you're calling it internal, that is okay. So don't say things that which you cannot defend. Unnecessarily, you're just going on and on. What lies close to it? Superficial temporal goes there. It's a terminal branch of external carotid artery. It's not the main artery which will lie deep to it.
Sir, if tumor is arising from the superficial lobe, then treatment will be only superficial parotidectomy. If it will arise from the deep lobe, then treatment will be changed, total conservative parotidectomy.
Now, okay, we will go to treatment part. How do you proceed now?
Yes, sir. I will. I would like to first confirm my diagnosis and support. And support my diagnosis. So I'll go for USG, parotid region and neck, and along with the FNAC of parotid swelling.
Your take on FNAC, Dr. Saab. Your take. He has said FNAC.
Yes, yes. In parotid tumor, FNAC is a benign parotid tumor. FNAC is accepted.
Now, I was in Maharashtra, I told you, and there was a big debate on this, whether you need FNAC at all or not.
Yes.
How would FNAC help you in this case?
Sir, it will help in planning for treatment, sir. If benign tumor or then superficial, if tumor is arising from only superficial lobe, then superficial parotidectomy. If malignant tumor, then
See,
I have to go for.
you are all over the place. The question is very simple. How does FNAC help you in managing your treatment?
Clinically, it was benign.
Clinically, the tumor looks benign.
Yes, sir.
What is the minimum biopsy in parotid?
Superficial parotidectomy.
Okay, you've done FNAC. If it shows pleomorphic adenoma, does it change your management?
No, sir.
The only time it can change you if there is suspicion of malignancy and you get malignancy, then your plan would be you can go for total parotidectomy, conservative or radical, depending upon involvement of facial now. Now, why I asked that question was general concept there was people were arguing against FNA. We all get it done. And also, especially in this part of the world, sometimes you get tuberculosis of the parotid, where you may not need surgery at all. So it's safe, but you should be prepared to answer that question. That although FNAC doesn't change my overall approach in this case, management is superficial parotidectomy.
Yes, sir.
Okay?
Yes, sir.
Now, you have done an FNAC, it is pleomorphic adenoma. Why do you want to do an ultrasound?
To see the whether swelling is arising from the parotid first, then to see the if deep lobe is involved and other neck lymph nodes involved, and whether swelling
Are you
is
saying something?
whether swelling is cystic and solid.
Cystic and solid, okay. Eco texture you want to find out. Okay, so shall we proceed? So we've done an ultrasound to look for deep lobe, which clinically is not there. Look, in parotid, many people don't like to do too many investigations.
Yes.
Unless there are clinical features to suggest any deep lobe involvement, there is no indication for doing it. But ultrasound improves your yield of FNAC because it can guide you to the actual place where you need to take FNA from. Very rarely you may find a lymph node in preauricular region, which can be a challenge because the lymph node can be due to many causes. But then by and large, we take it as a parotid swelling unless proven otherwise. How do you proceed now?
Now I'll do investigation for fitness of.
You've done that, and
Yes, sir.
we're not going to
Yes,
take any
sir.
more time because you've already taken a lot.
Now I'll counsel my patient about the surgery, about the disease, after then about the surgery, and scar of surgery, then complications of the surgery.
Right? Which complication you like to do?
Yes, sir. Facial nerve palsy and facial nerve palsy, seroma, and flap necrosis and Fry's syndrome, For that, I will
The
counsel.
patient would immediately say, I am not getting it done. Don't start with all the complications. The only complication we usually discuss with the patient is about facial palsy may happen, which may be palsy is temporary and it can happen permanently in some cases if we damage it or you're reckless. And you would also explain to the patient that surgery is required. Okay, if you count out all the investigation, all the complications that you read in the book, no patient will go for it. And it's not such a difficult surgery to go for. We are not discussing, it's a clinical case presentation. There will be a session on what is to be done during surgery. So I would keep that confined. Any question, Dr. Murthy? Anything?
If your patient says, I don't want to get operated, how would you convince? But you have to tell what could happen. That has to
Yes,
be
sir.
convinced.
I will tell to patient it's benign tumor only, but it may convert in malignant tumor also if she want.
What is the probability?
Sir, it's 10% in 15 years.
Another thing is, does it grow in size?
Yes,
Could
sir.
it be more cosmetically?
Yes, sir. Cosmetically, and it can grow in size and associated. She may have compressive symptoms also.
And you know it there is nothing like compressive symptoms. You can say that today's surgery is easier. Maybe after 3 years or 5 years, when it grows larger,
It will be a difficult
it will
surgery.
be difficult surgery. Chances of injury to the facial nerve will be more. Removing a bigger tumor. So that's a scenario which you should tell the patient so that you can convince the patient to go for a surgery.
You mentioned about the complication. One you said phrase. What will you tell the patient?
Sir, I will tell to patient after surgery she may have redness, pain, and sweating in region just in front of and behind the in front and below the ear while having food.
And what will you do to avoid it?
Yes, sir. To avoid that, I will first I'll take thick flap during surgery, and then
Okay.
I'll place the barrier acellular dermal matrix
How
or
much does an acellular dermal matrix cost? Good. You don't have to pay for it, so it doesn't matter. Nobody uses this barrier anywhere. Thick flap, or you can use a sternomastoid flap. You can put intervening tissue somewhere. Thick flap, or the best intervening tissue is parotid tissue itself. That's what people say. But since you're doing superficial parotidectomy, you'll have to get rid of that. And you can use a sternomastoid flap, which is what is used, or a thick flap. Okay? And the complications of parotid surgery are many F's: phrase, fluid, facial nerve palsy. So these three F's can be remembered. Surgery of parotid is surgery of facial nerve. You preserve the facial nerve and remove everything else. I will not ask you how do you look for it because we have a session on it. Okay? Any question from sir?
One question from my side. Any other benign parotid swelling you can think of apart from the two which we have already discussed?
yes, sir. One is Warthin tumor, then oncocytoma, and
80% benign, 80% of benign are pleomorphic adenomas. Then next adrenal lymphomas,
adenoid.
and they can also be a lymphoma. FNA is useful there also, but FNA cannot make a diagnosis of lymphoma, unfortunately. So a lot of ifs and buts about FNA. A lot of people don't like to do it. Minimum biopsy, superficial parotidectomy.
Have you heard of parotid cyst also? The swelling could be parotid cyst also.
Yes, sir. Lymphoid cyst in HIV patients, sir.
Bilateral HIV patients, you may have it, but not so common.
Yes, sir.
You will treat them clinically as parotid tumors only. The answer doesn't change. And cyst is not cystic. And you should not talk about pulsation when you call a swelling is firm. It can't be expensile, it can conduct all right. You're not talking about aneurysm. Don't talk about carotid artery there. These are things you should avoid in a situation. Any question from the students?
As such, we do it because the tuberculosis is quite common, and we do FNAs to have a diagnosis. Many times turn out to be thinking in terms of it is a pleomorphic adenoma. It turn out to be a tubercular lymph nodes which are there in the.
Puneet, kindly put your mic near your. Yeah.
And you can look here and speak.
I'm quite loud, I can say. Then my
Yeah, carry on, carry on.
Speak into the mic.
Apart
It's
from
working.
that, as such, we don't do other investigations like ultrasound, we can do it to rule out the other conditions. But of course, if the deep lobe is involved, we thoroughly investigate the patient with the CT or MRI. So investigation is required in the patients if they have a deep lobe involvement, because unless until we have a thorough investigation, we can't treat these patients and evaluate these patients. Because once the deep lobe is involved, we have to evaluate these patients in relation to the other vital organs. So we have already discussed about what are the structures which are in close relation to that of the deep lobes. In the
That I think
discussions.
was covered, no?
Important,
We
yeah,
were
it is very, very important to investigate these patients with further in like CT or MR depending upon.
Yeah, yeah.
The MR, sometimes people say better, it is only because the soft tissue structures are better delineated there on MR in this, or you can do a CT depending upon what you can do.
If there is a clinical suspicion, that's what we discussed. We skipped that part because what are the indications? The MR is not done, CT is done. Why? Where is CT indicated?
Sir, if any symptoms of facial nerve involvement,
Okay.
if deep lobe,
Deep lobe.
involvement,
Recurrent disease, remnant disease, deep lobe and lymph nodes. So there are indications for doing CT, but routinely
recurrent.
ultrasound, guided FNA is usually enough. Okay, interestingly what Professor Puneet just mentioned, there are, if you read the Red Book of American College of Surgeons, the American College of Surgeons recommends CT as a first investigation because for them X-ray is CT. But it depends where you are. But by and large, we don't do MRI for this area because it's not so sensitive. MRI is done if you're doing a recurrent surgery in a facial involvement because you need to know the planes. Then there are certain carcinomas like adenoid cystic which travel along the facial nerve. We need to trace it. So not extensive investigations are not needed for a benign pleomorphic adenoma where there is no clinical involvement of deep lobe, like in this case. And deep lobe involvement is quite clinically visible. You can't miss it on ultrasound. Okay. Dr. Puneet, can you join on the dais now? Now with that we'll conclude this case. If there are any quick questions, yes please. Please identify yourself and ask the question. Pass the mic there.
I'm Dr. Mohit from BLK. Actually, sir, FNAC, would it help in deciding whether we can go in for a extracapsular dissection also if we are not going in for a superficial parotid?
See, I raised that issue of FNAC which was again reiterated. FNA is something which we do as a routine.
Right. No,
More of a,
can we use as a justification? Like, one way was that for ruling out TB, the other one is for deciding the procedure.
I'm sorry, I didn't hear you.
I'm saying, can we use this as a justification? Like, one, we can say that for TB.
No, justification for what?
FNA, justification for FNA. Deciding on an extracapsular dissection instead of a superficial parotidectomy.
Ultrasound is an extension of clinical examination. Okay. In this case, I would do an ultrasound or not is your question. I may not. But the answer in the exam is usually evidence-based. That's what we do in the scope course. Ultrasound guided FNA in a variegated consistency guides you to the solid component so that you can get a yield which is more representative. Otherwise, it doesn't really matter. Asking your question about extracapsular dissection, why should you do extracapsular dissection in a pleomorphic adenoma? You're doing a superficial parotidectomy. So don't mix up things. Extracapsular, what do you understand by the term extracapsular dissection?
You incise the capsule, you take out the tumor and then you stitch the capsule.
But that's wrong. You should read about the capsule of the parotid also. So don't use terms which are not relevant here. Extracapsular dissection is done in malignancies only. If you're told you have to go extra out of it to get the masseter or the other surrounding tissues out. Is that okay? Coming to the point that Puneet was making regarding the facial nerve, regarding the role of CT, etc., we need MRI, sorry. We need to know where the nerve is and where the branches are when we have to do some kind of a reconstruction in a redo surgery. These are all indications of redo surgery. I think we should confine to the case, and that's what my job is. Otherwise, we are all over the place. We can keep asking questions which may not be directly related. Please, quickly. FNA shows adenocarcinoma. You do total conservative parotidectomy. Adenolymphoma, total conservative.
What is a multi-site?
We don't, it's not unnecessarily required. And let me tell you, FNA is a very poor investigation in parotid. It has got too many false negatives and nobody swears by FNA. We proceed for superficial parotidectomy anyway. And if you're in a clever center, you get a frozen done and you proceed. It's not free for all. You just don't do whatever you feel like doing. We here are supposed to answer questions in the exam which are to the point and correct and you can defend them. Is that okay? Now, superficial parotidectomy is the minimum biopsy. If that shows, it happens very commonly that you did an FNA, it was pleomorphic. Superficial parotidectomy shows it to be adenocarcinoma. You'll proceed with completion, or you do it on the table if you get a frozen. So let's not get into the controversy of, and there's nothing like extracapsular dissection. So let's not use those terms here. I think give him a big round of applause for putting up the first case. Well done.